Okay, we'll just give a few more minutes for others to join. You're welcome to, in the meantime, introduce yourself in the chat. Let us know where you're joining from. It's nice to see some familiar faces and some new faces. Thanks to everyone for joining us. So we're all here for informing youth, sexual and reproductive health during COVID-19. We're looking forward to this conversation and really glad that you're all here with us tonight. So I'll start by noting that we have simultaneous translation available for us. So if you'd prefer to listen to the conversation in French, please navigate to the bottom of your screen and select the globe interpretation icon and just choose your language of preference. Fanny's here tonight to do the interpretation for us. So thanks, Fanny, for joining us once again. It's nice to have you here. My name is Ashley Armstrong, and I'm a communications co-director with Interparis. And I'm just admitting a few others here. Great. And I'm joining you today from the unceded territory of the Algonquin people. We pay respect to the Algonquin people, who are the original guardians of this land, and acknowledge their longstanding relationship with this territory, which remains unceded. So for those of you who know us well, and for those of you who are new, Interparis, which means Among Equals, is a feminist social justice organization that believes in solidarity as an approach to international cooperation. Interparis's programs largely focus on 6 global issues: food sovereignty, gender justice, peace and democracy, economic justice, health, and migration. And we work with long-term counterparts like Likhaan, who are local and national social justice organizations in Asia, Africa, Latin America, and Canada. And for more information, you're welcome to visit our website at interparis.ca, or you can find us on social media. So before we dive into the conversation, I have a few housekeeping items to note. So if you need any tech support throughout the conversation, please feel free to chat me directly. My name is Ashley Armstrong. And the chat will remain open for the duration of the webinar. So you're welcome to pop any questions or comments in there, and we'll come back to them after the conversation. And for now, we'd love for you to introduce yourself in the chat. I see a few people doing that now, so thank you all. It's nice to see you. Just also to note that the webinar will be recorded, and we'll be sharing that with you afterwards. So I'm joined tonight by my colleague, David Brewer, and also Erick Bernardo from the Likhaan Center for Women's Health in the Philippines, and Jennifer Gibson from Island Sexual Health Community Health Center in Victoria, British Columbia. So David will be moderating the conversation with Erick and Jennifer, and then we'll have some space for questions at the end. So on that note, David, I'll pass it over to you to get us started.
I couldn't unmute myself before, but I see you gave me back the power. Thank you. So welcome, everybody. My name's David Brewer, and I'm a program manager here at Interparis. And I have the good fortune to be one of the people who gets to work with Likhaan Center for Women's Health in the Philippines. Interparis has supported the work of Likhaan since it was founded in 1995. And this is an example of our approach to the work of international social justice. We look for like-minded organizations in the Global South that share our analysis that poverty and marginalization are not due to bad luck. They're a consequence of inequality and injustice, both within countries and among countries. So we don't think of our work as being charity. We believe that these issues of social justice, we think of them as issues of social justice, and Likhaan is one of the organizations that shares that kind of analysis. But we also believe that social justice takes time. You don't change entrenched systems of class and gender overnight, especially when it comes to something like reproductive health. So allow me, for the Canadians in the crowd, a brief history lesson to illustrate my point. In Canada, in 1923, the first advocacy group was formed calling for the legalization of family planning. At the time, it was illegal and its use was punishable by 2 years in jail. It was legalized in 1969. 46 years of struggle. So I repeat, social change takes time. So we don't believe in short-term projects, we believe in long-term relationships. We also don't believe that it's our job to tell Likhaan what to do. As Ashley said, our name is Among Equals. They're the experts in their own context, and they know best how to overcome the obstacles they face. What we do is to work in solidarity with them. One of the ways we do this is to find funds to help support their work. So we ask Canadians to support inter pares and our counterparts. And I would like to thank all of you on this call who do that. Another way is we seek funding from the Government of Canada through Global Affairs Canada. And this lets us provide much larger resources to groups like Likhaan. So from 2016 to 2020, we had funding that supported Likhaan to establish a network of 4 family planning clinics in Metro Manila and Eastern Samar, providing free services to poor and marginalized women. One of the things we noticed was the difficulty in reaching adolescents through those clinics. And we currently have the support of Global Affairs Canada for a multi-year project to support Likhaan's work focused on that area of adolescent sexual and reproductive health. So thank you to Global Affairs Canada. At Interpares, we know that we don't have all the answers. Another thing we know is that there is great value in sharing experiences and learning from each other. So as part of our previous Global Affairs Canada funded project with Likhaan, we brought people from Likhaan to Canada to share the stories about their struggle for sexual and reproductive health and rights in the Philippines. And we particularly wanted on one of those tours to focus on work with adolescents, as this was one of the challenges that Likhaan had identified. And it was during the tour in British Columbia that they met with Island Sexual Health. And they had the opportunity to learn about some of the really wonderful work that Island Sexual Health is carrying out in education with adolescents. Sex ed is a huge challenge in a really, really conservative culture of the Philippines. And so we decided after that meeting up in BC, well, let's expand on that experience. And so in 2019, Jennifer, who's with us today, went to the Philippines to share some of that experience working with adolescents there in Manila with Likhaan, with teachers. And that is sort of bringing us to the webinar today. So we're very, very happy that we can bring these 2 amazing organizations together again. So from Likhaan, I'm really pleased to welcome Erick Bernardo. From Island Sexual Health, really pleased to welcome Jennifer. And we've brought them here today for a discussion around adolescent sexual and reproductive health, which we're going to do through a series of questions. Okay, so I've shared them with the 2 people beforehand. I'm not going to spring them on them. So they've had time to prepare. But we'll try and do that for about 25 minutes and then move on to taking questions and entering into more of a discussion with the audience. So I'm going to introduce both speakers now so that we don't have to sort of interrupt the flow of the discussion. Erick Bernardo is a registered nurse by profession who chose not to confine himself within the conventional 4 corners of a hospital. And in 2012, Erick left a very lucrative job in the business process outsourcing industry and worked for various projects in the development sector. before joining Likhaan Center for Women's Health. In 2013, he helped form the Philippine Society of SRH Nurses to advance the practice of sexual and reproductive health nursing in the country. He is a staunch advocate for sexual and reproductive health and rights, and he is the program coordinator for the Building Momentum project, which we have with Likhaan now, funded by Global Affairs. Jennifer Gibson is the coordinator of community education services with Island Sexual Health Community Health Center in Victoria, BC. She's a professional sexual health educator with whose knowledge, sense of humor, enthusiasm, and comfort level give her the ability to make sexual health education accessible and engaging. She's worked with ISH since 2004 and has facilitated sexual education workshops for more than 120,000 students and educators, which I find amazing. And for her master's degree, Jennifer published a thesis entitled Making Sexual Health Education Sexy for Youth, which in my books is a fabulous title. So I'm going to do one more thing before we jump into the discussion. And this is the chance for all of you participants, all of you attending the webinar, to demonstrate some of your knowledge of the issue around adolescent sexual and reproductive health. So you're going to see 3 questions come up and choose an answer, and let's see how well people do. So in Canada in 2019, girls, oh, these aren't in order. Oh, well. Age 10 to 14 gave birth to how many children? Okay, I think, there we go. Is that like, so 64 is the right answer. Well done, folks. 60% of you got it. Let's go. Okay, can we go on to the next one? How many children are born around the world to girls aged 19 and younger every year? Okay. Oh, okay. I think there we go. Once again, you guys are amazing. 13 million is the correct answer. I wish it was 1 million. I'm very glad it's not 20 million. Okay, final question. So in the Philippines, girls aged 10 to 14 gave birth to how many children in 2019? And once again, the orange wins. Okay, 2,411 is the very unfortunate correct answer. So thank you for that. Thanks for joining in our little poll. And now we're going to move on to what you've been waiting for. Can I get rid of that poll thing in the middle of my screen? Oh, good. Thank you. And I'm going to start, I'll start, Erick, with you, and the question is to both of you. But can you say, why is it so important to do this work on adolescent sexual and reproductive health in your context in the Philippines? And can you tell us a little bit about that context that you're working in?
Thank you so much, David, and thank you to Interpares for this opportunity. So as we saw in the poll, around 2,400 children 10 to 14 have become mothers already, unfortunately, in the Philippines. And I think we are getting more data now that more and more younger girls are getting pregnant over the days, and especially now that we're in lockdown in the middle of a pandemic, when these children who are very much vulnerable because they're not allowed to go out, they might even say, for example, they're in a live-in or in a cohabiting situation, and then they can't go out. So at the end of the day, they would come to our clinics pregnant again, even if they don't want another pregnancy. In 2017, when we had our National Demographic and Health Survey, uh, 15 to 19-year-olds were giving birth at around 47 per 1,000 live births. So we've been seeing a steady trend in the number of teen pregnancy cases. It's so unfortunate that the DHS only records 15 to 19, so we're completely blind of data on 10 to 14-year-old. Some of our colleagues are rejoicing because it went down from 57 per 1,000 to 47 per 1,000. But we at Likhaan are saying that if we would translate that to absolute numbers, it wouldn't mean a thing because the population back in 2013 is a lot different than the population in 2017. And more recently, I had a meeting with the Commission on Population and Development, and he was able to share recent data from the Philippine Statistics Authority saying that more and more adolescent minors are indeed giving birth. About 171 live births were born to minors every day in 2019. And the number of births from 10 to 14-year-old mothers is generally increasing. The Philippine Statistics Authority have noted about 7 live births were born in 2019. This is a rise of 3 births in 2011 to 7 births in 2019 in just a span of 8 years. More and more minors have also been reported to have had repeat pregnancies. And it's also been found that births among minor mothers are generally sired by older fathers who are 20 years old and above. So from that data, we can see that there's power imbalance. Young girls are being impregnated by older men, and the numbers of teenage fathers have also been steadily increasing from 2010 to 2018. The sad reality for the Philippines is that when we're talking about teen pregnancy, we're only looking at young girls who are getting pregnant. But uh, uh, one point of concern nowadays is that the number of teen fathers are also in the rise. So if we have to think of the future of these young girls, I think we also have to look at how these young fathers, how prepared or unprepared are they for the responsibility of fatherhood. Because what we've been saying is that while childbearing and childbirth is the sole responsibility of girls, but child rearing and raising a family is definitely the responsibility of both parents. We're seeing that some people would say that they in the local dialects it's accidente. Their pregnancy was caused by an accident, and we would usually say you don't get hit by a rushing penis or whatnot. So I think we really have to address the fact. We really have
Alin?
to we really have to address the fact.
Oo.
I think we really have to address this fact that this is really the sad reality. And just recently, a few weeks ago, we had a training, a conversation with youth leaders in southern parts of the Philippines, and it's so disheartening to note that teen pregnancy is considered normal. Is considered now the norm. Some were saying that if you don't get pregnant at a certain age, you would be left behind. I think I don't it's quite disheartening that that's how young people would in the communities would think about that. If you don't get pregnant at a certain age, all your counterparts would already be pregnant and you're the ones left behind. So I think the work that we do in adolescent sexual reproductive health, we know that we can't solve the entire Philippines problem. We can only do so much, but I'm thankful that we have the support of Interpares and Global Affairs Canada, so that in the communities that we're working on, we can at least reach out to these women and girls and even boys. And again, if we can't do something about the first pregnancy, at least let us help out in doing something to prevent repeat pregnancy. So I guess that's the importance of the work that we're doing right now. Thanks, David.
Oh, that's great. Thank you, Eric. That's really, really informative. I'm going to turn it over to Jennifer, and then I want to come back to ask you a couple follow-ups on that. But Jennifer, how is it? What makes it so important, and what kind of context are you working in BC?
Fantastic. Thank you, David. And so inspiring to hear about the work that Likhaan and Interpares and Global Affairs Canada is doing that I got to be a teeny little part of. So I just would like to recognize that I'm coming to this webinar from the unceded traditional territories of the Lekwungen and Musanich speaking peoples, which is often referred to as Victoria, British Columbia. So we're in different parts of Canada, even though we're in the same country, we're in different parts. So for us at Island Sexual Health, you know, when we look at adolescent teen pregnancy rates in Canada, they are significantly lower. And, you know, we're on the decline with our teen pregnancy rates. But I think that one of the challenges that has brought, you know, we're on the decline, we need to celebrate that, but I think it is in some ways invisibilizing the necessity for sexuality education. And we know that when we talk about, you know, unintentional pregnancies, young in life, unintentional, you know, in like motherhood, fatherhood, we definitely, that's an area that we need to focus on. But we have seen, one of the things that we have noticed a trend in is sexualized violence, that there's been quite an increase in reports and incidences of sexualized violence in our younger people. And part of this, I think, has been, we used to have a focus on sexual and reproductive health around the prevention of pregnancy, the prevention of sexually transmitted infections. And so there was a lot of conversation focused on those. There wasn't a lot of conversation on healthy relationships and assertive communication and consensual relationships. And we're seeing the real results of that. And that's a very large shift and a very large focus of the education that we are doing. I think also that there's an invisibilization of the necessity for sexuality and sexual and reproductive health education for all other health aspects in our life, how it connects to mental health, how it connects to, you know, our economic autonomy, all of these things. And we know, of course, that there are direct connections with that. And so I would say, and you know, that was certainly one of the things that was obvious in my tour with Likhaan, recognizing that in Canada, we have very much a place of privilege, but this privilege, I think, is covering up some real needs and some real opportunities for us to, you know, move forward the health of our adolescents. I think that there's this idea that, well, our teen pregnancy rate is going down, so yay us, we're doing a great job, but there's so many other connected issues that we really need to address. I can tell you that one of the most amazing legacies of my work in the Philippines and my amazing colleagues at Likhaan has been to share this information back with our students, because the students that I work with often see the idea of unintentional pregnancy very, very far away, right? It's not something that's so close to them. And so I think it's so important to bring this back on a scale of, yes, this is happening in Canada, but this is what's happening with global youth around the world. And that's really going to empower them towards this work towards social justice and really looking at this global approach to education and adolescent rights. So really that's the focus, and that's one of the biggest challenges I think we're facing, is that people will often say to us, well, but the teen pregnancy rates are going down and the sexually transmitted infection rates are going down. And those are only one of the markers that we really need to be paying attention to.
Oh, very true. I mean, I felt when I put the poll up that all the questions were about teen pregnancy, and I don't want to give people the impression that that's the only thing that this project is about, or that these two organizations are working on. I mean, teen pregnancy is one aspect of a much broader spectrum of issues. Erick, coming back to you, Jennifer was talking about the sexual and gender-based violence in the COVID context, and that is something that I think we've seen global trends upward during the pandemic. And so I'm wondering if you can talk a little bit about that in the Philippines, and but looking to the time before the pandemic, before you had lockdown, before you had all of the various restrictions with the pandemic, how easy was it to do this kind of work of adolescent sexual reproductive health, to get to the young people? Because my impression is, even in the best of times, it was a bit of a challenge, or it is a bit of a challenge in the Philippines. So.
All right, thanks, David. So for us in the Philippines, we have the Responsible Parenthood and Reproductive Health Law enacted in 2012. And the law states that adolescents who have given birth and those who have had a miscarriage can already access family planning services, so that we can prevent repeat pregnancies. But unfortunately, as the Philippines is a very much conservative country, this was challenged in the Supreme Court, and eventually the Supreme Court ruled that even if these young girls have already given birth, or they've already had miscarriages, if they're below 18, which is the age of majority here, they still need to present written parental consent. So that's one of the major challenge in getting services to these young girls. But for Likhaan, since we're fortunate to be one of the right drafters of the laws implementing rules and regulations, and the law specifically states that it should be interpreted liberally, and in the implementing rules and regulations, it clearly states that it provided in public health facilities, minor adolescents need to provide parental consent. So for the cases of Likhaan in our clinics, we don't actually require these young girls to present written parental consent. And we're fortunate to be working in communities for quite some time already, so that the parents themselves would be the ones to bring their children to our clinics, because they know that even if these children have had their children already, they would still be part of the family. It's not actually a reality in the Philippines that it's an escape to poverty. You get out of your family and go with your partner or husband or whatnot. And so there, they would still stay with their parents. And then these parents who are clients of Likhaan would usually bring these children to our clinics for contraceptives. So there, I think that's the major challenge, is that the law requires us, or public facilities are required that prior to giving services, much needed services, this minors have to present written parental consent. I even had an instance wherein I was, say, propagating the notion that this is what the law provides, this is clearly what the law states. And the former national program manager of the National Adolescent Health and Development Program of the Department of Health even threatened me, saying that, well, you can, of course, definitely give commodities to this minor adolescents, but just don't influence those in the public sphere, because once I've learned that you're the ones influencing them to give out the services in the absence of parental consent, because what we're saying is that if even if you give or you don't give, there's no punishment, there's no penalty in the law. So what's there to be afraid of? Would you rather have this minors go back to you pregnant again, rather than you help them out, prevent repeat pregnancies, or even better, prevent the first pregnancy? Why would you allow the restrictive provision of parental consent if you don't have penalty? So this program manager went on saying that if I learn that you're the one influencing them, I'll be the one to sue you in court. And I was like, what? Are you really working for the best interests of this adolescents? We all know that this is the reality, and yet here you are threatening me in a public forum and all that. And now she's in the geriatric department. So, and I'm still in the adolescent reproductive health movement and still providing the services. So, I guess that's the reality. And yeah, it's really challenging, even pre-COVID, and much more now that the lockdown is really targeted towards these minors.
Yeah, it sounds like a very, very challenging environment to work in, even without COVID and the lockdown. Can, before I jump over to Jennifer, just can you tell us a bit about the schools and what kind of education adolescents would get through the school system about not even comprehensive sexuality education, but kind of, what do they get? Do they get anything? And can you get into schools as Likhaan? I mean, I know that's something that Jennifer does, and we'll come to that, but what about the situation that you face?
So as I've mentioned, we have the RH law in 2012, and the then Secretary of the Department of Education was a religious person. So it took us around 6 years in 2018 prior to we need to have a change in leadership, a change in government prior to DepEd finally and putting out a policy on policy guidelines on the implementation of comprehensive sexuality education, which Likhaan, through a panel of experts, helped produce the standards for the Philippines. And I think Jennifer was able to see the standards, and now it was adapted in total by the Department of Education, and it's being integrated in the existing K to 12 curriculum. There were plans of starting the pilot tests or the initial rollout in several regions wherein there are high cases of teenage pregnancies and HIV. Because aside from teen pregnancy, we also have HIV in the rise for adolescents and young people 15 to 24 years old. So, but again, now that we're faced with the lockdown, with this pandemic, we don't know how this teachers would be teaching concepts of sexuality education to the students, because we're seeing that the lessons are taught modular. We have blended education, we have TVs, and the law and the standards that Likhaan was able to produce specifically states that it should be age and development appropriate. And it's just so fortunate that it was adapted But again, the implementation, we're looking at how, if there would be implementation fidelity, if what is being, if what is written in the standards, how would it translate to the curriculum? And we know for a fact that these teachers, there have been several studies that saying they're not that comfortable in discussing sexuality education topics. We were saying in the past that when you talk about sexuality education, you're not teaching kinder agers how to put a condom on. We're not teaching uh, younger girls about menstruation if they're not even menstruating yet. So basically, what we're trying to say is that comprehensive sexuality education will not make our school children promiscuous, but rather would give them skills to make responsible decisions, would show them that if you're ready to engage in sex, go ahead. If you're prepared of the responsibility, then by all means. But if you're not, here are your options. You have your contraceptives, which the World Health Organization and all the experts in reproductive health is saying that yes, you can use. So now we're working closely with the Department of Education, and because they're very firm that they can only provide information and education to this school age children. And we're saying that one of our non-negotiables should be the directory, because education, we believe, is a demand generation activity. So basically, if you're saying that if you're engaged in risky behaviors, you can use this, and it would be a shame if we don't give out, if we just limit the information to just the information. What if a kid reach out to you saying that, where can I get the services? And then the teacher or the guidance counselor or whatnot would say, I'm sorry, I don't know where you can get that. So I guess it's how it should be an interplay of the education and the health system, that if a kid would want the services, then definitely we should be able to provide the services through elsewhere.
Okay, thank you. That's really, I wanted to understand a little better about the challenges you've got. And I think when we coming back to you, Jennifer, that idea that, well, we have sex ed in schools, now I'm going to show my age here, but when I remember that, it was basically a diagram of the male reproductive system and a diagram of the female reproductive system, none of which I understood at all when I was a kid. And that was it. That was basically, and the teacher clearly didn't want to teach it. So have things changed? How are we doing now?
Well, you know, one of the things that was just so apparent in the work that I was lucky enough to do with Likhaan, especially when we did the teachers training, was how well this curriculum has been planned out, how comprehensive, how it really was leading the young people through their development, supporting age-appropriate information, pairing it with natural curiosity, with critical thinking skills that will translate to all areas of their life. And I'll be incredibly frank with you, the Philippines, as this is adapted and rolls out, Canada is trailing behind quite drastically. I can tell you that the models that you saw, the diagrams that you saw, David, some students would be lucky if they're still seeing those, quite honestly, in Canada. Quite honestly, we have a set of guidelines, right? But it falls down to the provinces, and then it falls down to the school boards, and then it falls down to the schools. So we have this trickle down effect. So we have a set of guidelines, but we don't have anyone who is assessing the curriculum to make sure that it's being provided. And this has become incredibly apparent through our pandemic response. We've always known that was happening, and we've always known that for us as an organization, the education has been very relationship dependent. So if we've had a very strong relationship with the school and a very high trust that we've built, the students get more education than schools that don't prioritize that. So in British Columbia, for example, there's been a shift of this education. We have taken it back from what used to be called career and life education to personal or to physical and health education. So it's gone back to PE essentially. But what's happened is they've put it back into PE without supporting the teachers in any type of professional development. So you'll have some teachers who are naturally, advocates for this and see sexuality as part of our overall wellness. And then you'll have others whose personal views, their comfort levels are then like roadblocks for that. One of the challenges that we face, so we're invited to come into a classroom and provide education. And as Erick has, so articulately pointed out, that students, you can't just give them the information, right? You have to give them the information which is going to increase their motivation and affect their behavior. So they need follow-up clinical services for that behavior to be implemented to support the information and the motivation. And as an organization, as a nonprofit, we've been lucky enough when we go into a classroom and we cultivate these conversations and facilitate these conversations, students who need follow-up then know where to go. They know what to expect. Whereas if a teacher's providing it, you're absolutely right. Like Erick, I don't know where you could go. I'm not really sure. And so you may provide them the information, but if they don't feel comfortable, if they don't know where to go, it just falls flat. And in fact, I think we're almost, you're creating, you're not creating curiosity, but you're creating this dialogue and, this place for this knowledge to sit, but then we're not following it through, right? So we need to have a continuity of learning and the community services. So that's probably our biggest challenge, is this shift back in British Columbia to PE without adequate training and without adequate services. And then of course, with the distance learning, we were, a lot of schools have school health clinics. Well, students last year were at home learning from home. They weren't allowed to go out. We are supposed to be socially distanced. So they now don't have access to contraception or STI testing or, other things. So there's a variety of roadblocks. And one of the things we did in our response when school went to distance learning was provide narrated PowerPoints so that they could be shown. So we did a set for the students, a set for the parents so that it could be supported with their families at home. And with all of the schools that we had booked for the duration of the year, which was about, I think, 37. And 2 of them used them because the other 35 classes didn't feel that that was a priority. The priority was on reading and arithmetic.
Oh dear. Well, I guess we've always known that priorities are one of the things you deal with. And I mean, I'm listening to this and I'm thinking of the really wonderful RH law and the great work that Likhaan has done around a comprehensive sexuality education curriculum, and how so you've set all of this stuff in place in the Philippines, but if nobody wants to use it, or if they are not, so you've got guidelines, but again, as Jennifer was saying, guidelines don't necessarily get implemented. So is that what you see in the Philippines, Erick?
I think if there's a beauty in the Philippine education system is that the Department of Education is not a devolved system. So basically what the national or the central office would say is that it trickles down up until the school level. But as what Jennifer mentioned, it would also depend on the priority of the schools. If they don't feel that this is a need, they might not really focus on giving this one. And since it's not a standalone subject, it's being integrated in 5 key subject areas from grade 1 up until grade 12. We don't know how much the teacher would focus on these topics. So to complement that one, to provide a supportive environment, one bureau of the Department of Education, the Bureau of Learner Support Services, is looking at putting up school-based teen centers. Although we know that in a global scale, teen centers usually don't work, but we're still supporting them in such a way that who knows, it might work in the Philippine setting. Because as what Jennifer mentioned, once you've motivated the students, definitely they would have more questions in mind. They would want more answers. And then where can they go to if you only have, say, for example, 15 minutes out of the 40-minute subject in science when you're talking about these topics? And so we're looking at putting designate guidance counselors or even school nurses, so that if these children would have questions further, they would have someone to talk to, and yes, they can refer them to the services. So yeah.
Okay, I'm conscious of the time here, and I know, Jennifer, you spoke a little bit about how the pandemic had affected some of the work that you were doing, and sort of the need to move online, the fact that there was the in-person was not there. So I'm going to come back to Erick on this one and say, can you speak a little bit about how you've had to adapt to that pandemic? And then after that, I think we're going to move right into questions and discussion, just in the interest of time. So sorry, Erick, I'm turning it back to you, and to just speak a little bit about the pandemic and how that's affected the work of Likhaan.
So basically, we have shifted our education work because for Likhaan, we have 3 core programs. We have community education and organizing, we have clinic services, and we have policy advocacy. Although health is still considered an essential service, so we still have our clinics operational, but this pandemic, all this lockdown has definitely slowed down our community education and organizing work. So now we're using, relying on technology, which is unfortunately unreliable here in the Philippines, to reach out to adolescents and young people. So we're using Facebook Messenger groups, we're using SMS to send out text blast or send out information to this adolescents and young people. And Likhaan was able to produce pre-pandemic, pre-COVID, a chatbot wherein adolescents and young people can reach out and talk about their concerns. So it's pre-programmed with information on various SRH topics such as puberty, menstruation, violence, family planning, SAHIV, and whatnot. So we're relying heavily on that now to reach out to this young people, and we're seeing that memes and infographics on social media are the in thing for these young people. So we're trying to produce this now. We're bombarding them with information saying that we have this one. It's better to be prepared than not prepared at all. And then instead, we're delving away from the usual image of a condom, say, for example, to protect yourself. Say, for example, if you need protection, use a helmet. And then we put there that if you want protection, then use a condom. I mean, we're doing that in such a way that it would be enticing to young people, because if you would see a helmet posted on SRH page, you would think, what does helmet have to do with sexual and reproductive health? And then we would link it up to the chat bot, and so that if they would have questions how they can get themselves protected from unplanned pregnancies or even STIs, including HIV, then of course they can definitely use a condom. So that's what we've been doing now. We're fortunate to have youth community mobilizers who are also into social media. So we're also investing on their skills to produce that one, to reach out to our clients.
So Jennifer, while we wait for questions from the audience, I'm going to throw another one at you, and just one, because you were talking about memes before we started this thing. So I'm just wondering if that is that the same for you, that the
You
youth
know
want-
what? Absolutely, yes. So I was sharing, everyone who's joined us, I was sharing that my colleague, he does cat memes for the grade 7 workshops we do, and they just love it. And then they see me in grade 8 and they're like, your memes are not very interesting. Your colleague had way better memes. But this is what's universal, Eric. Like, we've turned to social media with us as well. With us, our demographic of youth aren't using Facebook so much. It's me, like the old lady who's using Facebook. It's Instagram. So they're using Instagram and Snapchat. We're doing a lot of education, and TikTok is just huge. And so we're doing a lot of uneducation because of the educators on TikTok. So we're doing a lot of re-education with that. So we're using social media a lot. One of the things that we do, you can see over my shoulder here, is a texting line for youth. So in our classes, we give out the cards, and that's to be a resource for them if they can follow, so they can follow up afterwards if, you know, when questions come up in their lives. This is an interesting thing. So we're teaching virtually now. We're not actually back in the classroom. We were in the beginning of the school year, and then we've had to withdraw because as the numbers have gone up. So I'm zooming in, just like I'm zooming in with you two and everybody else today. That's how I'm teaching sexual health. I'm like the talking head in the screen. And the youth use the text line for anonymous questions. Rather than write it on a piece of paper and fold it and hand it to me when I would be in the room, they use this texting line. And I ask them to, when everybody texts either a comment about the workshop and an emoji, or a question and an emoji. And the reason they send the emoji is because the texting line also receives questions from the community, anyone in the community. So we need to decipher, is this question coming from the class so I can answer it in real time, or is it someone outside of the class? And so the emojis, you can imagine, are very, very fun. And they get to be cheeky and, you know, exercise their adolescent cheek. But what we've noticed then is they then follow up with texts a week later, 2 weeks later, 3 weeks later, 4 months later, and we're able to track that. So that's showing us that need for continuity outside. And before, we had no way of knowing where they were getting those, you know, when they were using the line afterwards. And now we can absolutely see when they've used it. So it's actually been really beneficial because they have the number in their phone. They don't just have it on a card. They have the number on their phone. So then there's their motivation and their behavior.
Okay, I have a couple questions. I think that sorry, I didn't want to cut you off at all there, Jennifer.
No, you didn't.
But the first question, and I'll direct it first to you, Eric, but then maybe Jennifer, you can jump in as well. And it's about how, if at all, do you reach out to youth with disabilities? So that, is that something that Likhaan is able to do? And if so, you know, what sort of strategies have you got? How are you approaching that?
Okay, for the Philippines, unfortunately, people with disabilities in general are still somehow left behind in terms of sexual and reproductive health. We had this conversation with deaf community, a group of persons with disability, and then they were being ridiculed at or discriminated, saying that you're already a person with disability, why do you need sexual and reproductive health for? So that's unfortunately what's happening here. Even the National Council on Disability Affairs is just working now towards reaching out to this vulnerable population as well. Well, for Likhaan, what we've been doing is that since we have a strong connection with a PWD group, a group of disabled persons with disability, they call themselves Women with Disabilities Taking Action for Reproductive Health. And we would usually get invited to talk to them about how we can engage them, and we would usually provide them services on demand if one of them would need contraceptive information, we would usually do teleconsultations, because part of our adaptation right now is also doing consultations and meetups. So this is our way of outreach activity. In the past, if we would usually do 100 outreach, now we would consider one-on-one meetup as an outreach, just to get these clients. So we would usually use that one. And we also, since now that we're in a lockdown, movement is restricted. So we would also usually use the couriers we have, such as Uber, or for the Philippines, Grab. And we would usually send out pills. We would send out the commodities using these platforms. And then that's of course after giving them information on how to use the pill, what to do if they if in case they missed out on a pill, who they can talk to if they have concerns. So there, I guess we're slowly getting there, but we're not as fast as we are. Again, the RH law was enacted after almost 16 years of struggle. CSE after 6 years, and hopefully we'll get to persons with disabilities soon enough.
Yeah, it's everything is an ongoing struggle, and where are we in Canada on that, Jennifer? Is that
Well, you know, speaking within our organization, again, we're not where we need to be, absolutely not. But we are, I would say in the, you know, the past, especially 7 or 8 years, I have seen more students with disability be included in sessions, whereas before they would be taken out because, as Eric has said, they would have been looked upon like this isn't connected to their wellness and well-being at all. And there's been quite a response by their parents and by community workers and community organizations to say no, like they absolutely, everybody deserves this right to this education. And this is about understanding how your bodies and your feelings and your choices, like all of this. And this is just because the focus might be on sexuality, these skills and this information is transferable to all areas of our life. And as Eric mentioned, we know that people with disabilities are, you know, multiple times more likely to experience abuse because they are more vulnerable populations. So I think we have a ways to go, but one of the things that we've done a lot of is to work with, within the school system, we have special education assistants. So we've done a lot of work with the special education assistants so that when they're working one-on-one with a client, they can have these conversations in a way that's more personalized and will help to build this information. Because we know, especially if someone has you know, they're not neurotypical, they have neuro challenges. Being in a session, I mean, anyone being in a session once is not enough, but especially someone who needs to hear this information in repeated, different creative contexts, that's where the education assistants come in, because they have these relationships of trust and they can really follow through these messages. Mm-hmm.
no? Thank you. That's great. I think. I know we've reached the end of our time, which is, it's too bad because I had another question that was in the chat, but well, let me try and see if it can give you like 30 seconds each on this. And the question was really about advocacy. So you've identified a whole lot of problems. You've said that we've got some good laws in place, but they're maybe not implemented. How do you put pressure on the government to change things, to improve things, or on the Ministry of Education? So Eric, I'm going to turn that over to you first.
Okay, I think it's high time that rights holders, the citizenry, must really demand for the services, because I think if the government or the duty bearers would feel that this is not something that their constituents need, or they don't demand for these services, then I think it would not, they would set it aside. They would think that in the time of pandemic, sexual reproductive health is not a priority. but we all know that's not the case. So I guess it's high time that it's time that people demand the government that uh, even though we're in the middle of a pandemic, pregnancies wouldn't stop. Those who are taking their antiretrovirals for case of HIV still need this life-saving drugs, and those who are in abusive relationships still need sexual violence measures. So I guess we still have again the work of Likhaan is not does not stop just because we're in the middle of a pandemic. All the more that we have to provide the services during this emergency times.
I think, it's also about normalizing sexuality as a human experience and validating it and affirming it. And so, that's where the education piece comes in, because when I go into a kindergarten class, they're comfortable, they're curious, they are like, this is like really empowering information to them. And so we build upon that. If we wait too long, and we don't tell them anything, there's opportunities for shame and stigma to creep in. And once we have shame and stigma, it takes a long time for us to strip that back and to re-educate people. And that's connected also to our pandemic response. One of the things we said was you can only access, don't burden the healthcare system, only access for essential healthcare. And reproductive health wasn't considered, like that was never named by the government. And so I think that's part of it is, as Erick was saying, is, let's recognize reproductive and sexual health as important as any other aspect of health. And let's talk about how to access this. One of the surveys that came out of Canada actually said that 35% of people who required, it was actually out of BC, sexual health care would feel shame actually getting sexual health care during the beginning of the pandemic response because they were supposed to be social distanced. And so one of the things we did was use social media to say, if your social distance has been more social than distance, still come and see us, right? We're not here to judge you. We're here to help you be healthy and well. And your choices, we want to support you in whatever that looks like. So I think that's the other thing is really, just meeting people where we're at. And that's different in different cultures, of course. Right?
Yeah, absolutely. I mean, I think that, well, I'm not sure if Elizabeth Holland from Global Affairs Canada is still on, but I just wanted to say, if she is, that was kind of exactly oh, great, you are. This is the pitch that we gave to Global Affairs Canada in terms of the additional COVID response funding for Likhaan, that the healthcare system during the pandemic was saying, well, reproductive health is not a priority. What we've got to do is COVID response, COVID response, COVID response. That's it. Which, if you are wanting to get contraceptive pills, wanting to get your injection, wanting to get, leaves you in a very tough spot. And so, thank you, bravo to Global Affairs Canada for giving some resources to Likhaan to scale up and kind of fill in some of that gap. I mean, it's obviously not going to fill the whole gap in the whole of the Philippines, but at least we can, I think it's fantastic work that has been enabled by that. So I just wanted to sort of give a shout out to Global Affairs for coming through on that one. We are definitely over time now. So I'm going to wrap this up. I'm going to say, first of all, thank you very much to Erick and Jennifer for letting me grill you with all these questions, and thank you for the responses, the discussion. Thank you to everybody on the call for the questions, for listening, for participating in our poll. You're all very good. You got, majority of you got the right answers, which I didn't get when I first did it. So so I think that's a good sign. we are aware of these issues. And thank you to all of the people for your support for Inter Pares. We appreciate it very much. We look forward to future webinars, to future contact with everybody. And thank you. Have a great night. Everybody, please stay safe. We will get through this pandemic at some point. Not sure when, but so thank you on behalf of Inter Pares. We really appreciate it. And if there are questions, I think there may have been a few questions that I didn't get to. We'll try and get them by email to both of our presenters tonight and get you answers for that. And yes, so thank you very much to Fanny for the interpretation. We are going to make the recording of this available in French and English. So we really, really appreciate the interpretation tonight. Thank you.
Thank you, everybody. Stay well.
Thanks, everyone.
Thank you. Goodbye.